Thank you. Well, first I want to say how grateful we are to you for sharing Joshua's story with us, painful as it must be as a mother, giving us this opportunity to take a closer look at the parent-patient-doctor relationship. We appreciate that. And also thank you to Nirali for taking a moment away from your truly groundbreaking immunotherapy research on CAR T cells. Leigh, can you start by telling us about Joshua, who he was as a person? What was he like?
Joshua was a very special boy. Of course, every mother thinks their son is special. He was very cerebral and thoughtful and had an amazing imagination.
We have some pictures.
Yeah.
We'll put them up.
And he made me laugh every day. And had the most amazing big green eyes with really unbelievable lashes that, people would stop in elevators and make comments like, oh, my. But and he was funny. I mean, that's Joshua. He always took any opportunity he could to make people laugh, which was nice. But he was also a very ordinary boy, teenage boy.
When did you notice he was getting sick, and how many hospitals and doctors did it take to get to the right diagnosis?
So it started one December afternoon. He got off the bus complaining of a sore throat and a headache. And he had a fever that over the course of a few days wouldn't budge with Tylenol or Motrin. And, then when he stopped swallowing his saliva, that's when it's like, oh, this is a bad throat infection. We took him to the emergency room. But he had an unusual presentation with a 0 white blood cell count rather than a high abnormal count. So it took us a little while. His first hospitalization didn't catch it because they didn't do a bone marrow biopsy. But he kind of bounced back, and then a month later, we were back in the hospital with a fever, and that's when they did the biopsy, and his bone marrow was chock full of leukemia. And after he didn't really go into remission from that first course of standard treatment, we got referred to Hopkins, and we went pretty much from 4 months from diagnosis to transplant because we realized his leukemia wasn't going to respond to the normal treatment.
4 months. Now, Nirali, the doctor-patient relationship is a critical thing. How did you two first cross paths, and how did your relationship evolve?
So we first met after all of these initial events when he had relapsed after transplant and they were looking at other therapies. So I currently work in the Pediatric Oncology branch of the National Cancer Institute, and our primary focus is on early phase clinical trials. My role there has been to advance immune-based therapies for children with relapsed refractory acute lymphoblastic leukemia. And so the doctors at Hopkins were the ones who referred Joshua and his family to us.
Mm-hmm. Well, survival rates overall for childhood cancers are high, but how does CAR T-cell therapy in particular offer even more hope?
Yeah, so ALL is a very curable childhood cancer overall. We're talking about 80 to 90% cure rates. But it's also the most common pediatric cancer, and it's that patients who have relapsed or refractory disease that still account for it being one of the leading causes of childhood-related cancer mortality. CAR T-cell therapy is a way of taking the immune system and reharnessing it so that it can attack leukemia, and so it overcomes the inherent resistance to chemotherapy that the leukemic cells have evolved into, and so it's trying to overcome that barrier. And based on the early response rates, it's now, one of the CAR T-cell therapies is now FDA approved, and we're seeing that it really has a tremendous potential.
Leigh, how was your experience with that therapy?
So, Joshua's leukemia had just, it was a beast. I mean, it managed to overcome everything that we had thrown at it. And, it just came to the point where, they said, let's think outside the box. What else can we try? And like Dr. Shah said, she had a very close relationship with the doctors at Hopkins, and we ended up doing one immunotherapy trial until the T-cell was ready. So it was kind of a bridge, and he did really well on that. And it's almost like his body got stronger and he was able to heal. And then when he stopped that trial, he did relapse, but he wasn't sick. I mean, the cells were there. And we went straight to CAR T-cell, and it did exactly what it was supposed to do. It got him a bridge to a second transplant. And he did, really well with it. it just, it's all about timing of where you are and what's available and if they can take you and if the numbers are right. And, I consider that we got really lucky for the timing to have worked out to have done Tcell at NIH.
Now, over the course of your experience, you had varying levels of care. What was it like to notice mistakes in Joshua's care?
For me, the way I coped with everything is I really needed information to stay grounded and understand what was happening and why. And when you push for the information and you push for understanding, you find mistakes. And there were, I'm not talking about NIH, but there were medication errors, there were communication errors. And I often say, through this whole thing, half the time I felt like I was in a master class in human behavior, and half the time I was the victim, and half the time I was the teacher. And so in catching some of those mistakes, it was how do I, put this forward that I'm watching and I'm paying attention, and I'm not going to stand by, but I'm going to be a partner in his care, and that's how I wanted to be viewed. But then, there's also, with Dr. Shah and I, there were times where, I pushed back on her, and she and I collaborated and compromised. And, Joshua wanted to go to Camp Sunrise for a few days, but it was timing-wise for the trial, the Tcell trial. And so we ended up letting him go for 2 days. And she said, just keep him out of any of the creeks. I'm like, okay. So he got to go for 2 days, and we picked him up, and we took him straight to NIH for the Tcell trial. And I have to tell you, it was one of the hardest days ever doing that. But, it was so important. And then there were other times where, I wanted him to get a drug that would boost his white blood cell count, because he was neutropenic and he was so vulnerable, and we'd been in that position before, and we'd faced such serious infection. And I pushed her and I said, why are we waiting? Just, can you please give him the GCSF? And she's like, okay, we went back and forth, and, it was all a collaboration. And I think she understood the place of which I was coming was not to be annoying or interfere, but that I was really, completely invested in, trying to understand the situation.
Is that how you felt?
Yeah, so I think that we really have to think about this as a care team model, and the families are part of that care team. And I think that it's really important to have as good communication, as open communication as you have, whether it's good information, bad information, an intense negotiation. When Leigh and I talked before coming on to this, we talked about the GCSF, and, it was myself and also several of my colleagues, including Dr. Leigh, who was leading the trial at the time, and we had not done GCSF in the setting of CAR T-cell therapy, and there were a lot of questions, and, that was a negotiation at the time, and now we do it standardly. So I think that the other thing to remember is that in early phase clinical trial work, our patients do inspire us. They force us to think about it. Our families force us to think about how we can do things differently, better, learn. And then we put those into practice with future iterations of that.
We'll be taking audience questions at the end, so get them ready. But first, Nirali, what breakthroughs are on the horizon in your research at NIH, and what is the ultimate goal for the CAR T-cell model?
So the biggest problem right now with CAR T-cell therapy is that, at least for the FDA-approved CD19 CAR construct in children, there's still about a 50% relapse rate at about 1 year. And a good majority of those relapses are because the leukemia has actually evolved and lost the surface marker CD19 on it. And so the things that we're working on at the NIH and elsewhere is to find out ways to overcome those relapse mechanisms. Ideally, we would want CAR T-cell therapy to be the cure. But I think that there are hurdles that we need to overcome to do that. We're currently working on combination strategies, so you have to go back to the foundation of chemotherapy. So, one agent doesn't work by itself. You have to use multiple different chemotherapies and optimize sort of that synergistic approach to make the leukemia not come back. So we're currently working on optimizing combinatorial strategies. So one of our CAR T-cell trials currently targets 19 and 22 at the same time. We're also working on developing CAR T-cell for other other leukemias, we should hopefully have a trial this summer targeting acute myelogenous leukemia or pediatric AML. So going into that, and then other members in our group, and also are working on CAR T-cell therapy for solid tumors.
Leigh, you've turned helping grieving families into your life's work. Can you tell me about the organization CaringMatters?
So a year ago, I started working for a local nonprofit in Montgomery County called CaringMatters. And it's been around for 30 years. It used to be Hospice Caring, we just rebranded, but they provide social support services for people who are facing serious life-limiting illness and grieving the loss of a loved one. And for me, doing communications and education, I really feel so fortunate because I'm my authentic self. It's not a stretch for me to talk to people about what it's like to be a caregiver when you have a seriously ill family member, what kind of support you need, and how it changes your life. And really, the after, when you are facing loss and then you're grieving, and the kind of support you need and the things that are helpful and the things that aren't. And I'm able to go to work every day and be my most authentic self. I mean, my loss, losing Joshua changed my DNA. It changed who I am forever. And although I still love my family and I take joy in life, it changes the way you look at everything. So I feel very grateful to be able to go to work every day and help people from a place not only of knowledge and experience, but just really true empathy and compassion. That's very hard won.
Oh, that's wonderful. We'll be taking audience questions in a moment, but first, what advice would you give to parents who've just learned that their child has a cancer diagnosis?
I really feel like the thing that helped us the most was information, like trying to understand, what is it that you're doing and why, and having the information to kind of manage the expectations for yourself and your child. And I feel like so many times there were certain things that people could have said to us that would have lowered the anxiety level a little bit and kind of laid out the different possibilities. Like, we're going to put an NG tube in and we're going to listen and we're going to see if it's in the right place. But sometimes it doesn't get in the right place and we have to take it out and try it again. Now, if somebody would have said that to us after that very first time and it didn't get in right, and I was like, what do you mean you have to take it out and do it again? And Josh was freaking out. And like little turns in communication that can really smooth the path. And so if people can look for those opportunities to kind of dig for the extra information and the extra clarification, it really can help keep you grounded when it feels like you're standing on shifting sand. That will never be solid again.
Oh, such good advice. Does the audience have a question? Anyone with a hand up? I see one in the back. Way in the back.
Thank you. Hi, my name is Beverly Paul. I have a question for Dr. Shah. When you talk about how important it is to try to get into a trial, are there enough trials for all the kids?
So before this, we were talking about how one of the things that pediatric oncology does really well is that we have a really large collaborative network. The largest organization is the Children's Oncology Group, and we really recognize that childhood cancer, all of the diagnoses are rare tumors or rare cancers, and that we need to have collaborative efforts. And those trials range in from very early phase 1 clinical trials, to phase 3, where you're really trying to change what the current standard of care is. And so Children's Oncology Group is a great force in that. In addition to that, there are several other consortiums and groups that are doing early phase clinical trials. I think one of the things that we would like to see more is that children have improved access to trials that are currently just for adults. I think that there are, ethical standards where you really want to limit exposure of early phase trials to children where there isn't a proven efficacy. But I think we need to keep in mind that there may be drugs that could be beneficial in pediatric cancer that may not have necessarily the proven outcomes in adult cancer, some of them which are very biologically different. And so I think we need to think a little bit more creatively about how to get children to some trials which may have potential benefit for them in unique circumstances.
Any other questions? Yes.
Hi, I'm Lyra Dory. This is for Dr. Shah. Are you all looking at when children go to their regular pediatrician just for a regular checkup, is there something that can be done to diagnose a particular symptom that may appear later in life rather than wait until it actually happens? Is there some testing that can be done earlier with all children to see if there's maybe a potential that they could actually carry a cancer cell?
So nothing that is done on a regular or a standard basis. Again, children's cancers are still quite rare. But if you know that there is an inherited syndrome or a family predisposition, those children are cared for differently, and there are specialty places and other clinics for them to go to look for whether there is a pattern of inheritance. But that is not something that is routinely done, nor do I think it should be unless there is a strong family history.
Do we have one last question?
Hi, good morning. Another question for Dr. Shah. My name is Ulrika Salai, and I am the founder of Canines and Kids Foundation. We're working on translational and comparative cancer research. So I'm particularly interested, as a pediatric oncologist, physician researcher, your perspectives on the level of investment in basic science, specifically to understand childhood cancers, which, as we've pointed out a few times now, are fundamentally different from those in adults. What are the types of things that we should be doing, that we should be funding? What's the magnitude of the gap, if you will? Some perspectives would be interesting. Thank you.
That is a really hard question to answer as comprehensively as I would like to. You ask a really good question. I think the foundation of therapies really is in basic science and being able to fund that and then take it to the next level and then take it to the next level. And so I think there's a couple of ways that we can. I think part of the problem is that it takes a really long time to have something that is basic, truly basic, make it translational to know that, the basic science idea that you have has clinical relevance, to test that and to bring it out to the clinic. If you look at the timeline from sort of bench to bedside, a lot of the things take a really long time. And so things that may speed up that process is to think about doing things that are a little bit more collaborative. And again, pediatric oncologists do that quite well. If there are drugs that are being developed for adult indications that are further along, trying to repurpose them and think about those in pediatric cancers, I think is another way to shorten that time frame. And again, I think we're really trying to figure out sort of multifactorial ways or multimodal approaches. In pediatric cancer, and I think one of the things that needs to change in terms of the paradigm of how new therapies evolve is that we do a lot of single agent testing, which makes sense. You need to understand how one drug works before you put it into combination therapy. But a lot of times a single drug, if it's just going to be an immunomodulatory agent or do some small thing, it may not be enough to get the signal that you want outside the setting of a combination therapy. So I think, again, creative trial designs are going to be helpful. You could have maybe a window phase where you introduce just a single agent therapy, but very quickly put it into combination so that you don't have a patient whose disease is progressing while you're waiting to see that activity. But again, some of those things are really hard to do. Josh was on a trial where it was multi-agent chemotherapy, where they put in two agents with other and testing that did lead to some sort of more toxicity than we would have anticipated. We had to decrease the dosing of that. And so I think there'll be windows of opportunities to figure out the best way to decrease the timeline.
Leigh, just on our ending note, how's your family these days?
We're good. I'm feeling great right now. I was just out in California for a big family get together and a birthday party, and it just, family is more precious than ever. And we talk about Joshua and we honor his memory every day. My daughter is 22 and was his first bone marrow donor. And, it's a special connection that we all have to him. And because of how hard we tried to save him. And I put on his headstone, if love could have saved him, he would have lived forever.
Beautiful.
Yeah.
Well, thank you so much for sharing your stories, his stories. We very much appreciate it.
Thank you.